Hello, my friends. Nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're gonna talk about the part 4 of the Fleischner Society 2024 glossary of terms for thoracic imaging. Let's go. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society Glossary of Terms for Thoracic Imaging by Alexander A. Benkier et al. Radiology 2024, 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Infarction pathology. Infarction is the result of parenchymal damage from vascular obstruction or occlusion caused by either emboli or pathologic changes of a vessel wall. At imaging, a pulmonary infarct is typically a triangular dome or wedge-shaped opacity with base abutting the pleura and apex directed toward hilum. The opacity reflects the local hemorrhage or edema and necrosis and late organization and or scarring, or a combination of these, depending on timing of imaging during natural history of vascular occlusion, embolus. However, many infarcts seen in acute pulmonary embolism are due to edema and hemorrhage without necrosis and hence are not true infarcts. Interstitial lung abnormality pathology. Interstitial lung abnormality is an umbrella term used for often subtle interstitial CT abnormalities in non-dependent parts of the lungs, detected incidentally. They often manifest as variable combinations of peripheral ground glass opacity and reticular opacities, which should affect more than 5% of upper, middle, or lower lung zone, as demarcated by levels of inferior part of the aortic arch and right inferior pulmonary vein, respectively. The term is not necessarily associated with presence of respiratory symptoms. Interstitial lung abnormality pathology. Arrows indicate both lower lobe posterior portion, the interstitial lung abnormality. Interstitial lung abnormality pathology. Arrows indicate the site of interstitial lung abnormality and right lower lobe. Interstitial lung disease pathology. Interstitial lung disease is an umbrella term used for a large group of lung diseases that involve the interstitium and are typically associated with restrictive pulmonary impairment. These conditions are, in fact, very often multi-compartmental and may then also involve the pulmonary air spaces, airways, and vasculature to varying degrees, and some may result in pulmonary fibrosis. Interstitium anatomy. The interstitium consists of a continuum of connective tissue extending from most central to most peripheral components of the lung parenchyma, which mechanically supports the airways, vascular structures, and alveoli. Anatomically, it forms a single interconnected space encompassing entire lung. For didactic reasons, it is divided into 3 compartments. 1. Axial, portion of interstitium that envelops airways, vascular structures, and lymphatic vessels, the combination of which are sometimes referred to as bronchovascular bundle. 2. Interlobular, peripheral, portion of the interstitium that extends from the visceral pleura and forms the envelope of the secondary pulmonary lobule and is visible as interlobular septa on CT examinations. 3. Intralobular septa, portion of the interstitium within the secondary pulmonary lobule that serves as the support structure for alveolar walls. Irregular anatomy pathology descriptor. Irregular is a general term describing the margination of a structure. For example, a pulmonary nodule or its components as not smooth and/or uneven. More precise descriptors falling under this general term include lobulation and spiculation. Juxtaphrenic peak anatomy. Juxtaphrenic peak is a small triangular opacity based on either the right or the left hemidiaphragm, with its tip pointing toward the lung apex, caused by upward retraction of an inferior accessory fissure or an intrapulmonary septum associated with the pulmonary ligament pleura. The retraction reflects the volume loss in the ipsilateral upper lobe, for example, after radiation or surgery. The peak is best visualized on frontal radiographs and coronal CT reconstructions. Juxtaphrenic peak anatomy. Arrow indicates juxtaphrenic peak in right upper lobe lobectomy patient. Lobe anatomy. The lobes are the principal divisions of the lungs. The right lung has 3 lobes and the left lung has 2 lobes. Each lobe is enveloped by visceral pleura, except at the hilum or when an interlobar fissure is incomplete. Lobulation anatomy, pathology, and descriptor. Lobulation is the descriptive term referring to a lobule-like and often asymmetric protrusion at margins of a structure, for example, a pulmonary nodule or its components. Pathologically, lobulations often reflect different rates of tissue growth or the presence of different tissues within the same structure, and typically have smooth margins. Although lobulation is often seen in malignant nodules or masses, it can also occur in benign lesions. Lobulation anatomy, pathology, descriptor. Arrows indicate the lobulation of lung nodule. Lymph node anatomy. Lymph nodes are organs of lymphatic system surrounded by a fibrous capsule and divided into outer cortex and inner medulla. The hilum is an indentation on concave surface of lymph node where lymphatic vessels exit and blood vessels both enter and exit. Normal lymph nodes are best seen on CT exam where they appear as round, oval, bean-shaped structures, sometimes with a visible fatty hilum. For purposes of cancer staging, mediastinal, hilar, and intrapulmonary lymph nodes are classified according to anatomic stations. Lymph nodes present in the lung parenchyma are called intrapulmonary lymph nodes. They are typically lobular and triangular in outline and occur along pleural surfaces, interlobular septa, and at vascular branching points. Aggregates of lymphatic tissues without capsule, as commonly seen along pleural fissures, are, strictly speaking, not lymph nodes. Lymph node anatomy. Arrow indicates normal fatty hilum of paratracheal lymph node. Lymphadenopathy pathology. Lymphadenopathy refers to any pathologic transformation of lymph node with regard to size, shape, and morphology. In more common usage, the term refers to abnormal enlargement of lymph node. Therefore, the synonym lymph node enlargement is more precise and thus preferable. On CT exam and depending on clinical scenario, the somewhat arbitrary threshold of either 10 or 15 mm short X diameter is often regarded as upper limit of normal. Because lymph nodes commonly show a wide range of sizes according to location, differentiation between normal and diseased lymph node based on size alone is unreliable and should be complemented by consideration of location and morphologic features or with assessment of metabolic activity by FDG PET-CT. Lymphadenopathy pathology. Arrows indicate right interlobar lymph node and subcarinal lymph node enlargement due to right upper lobe adenocarcinoma of lung cancer. Lymphadenopathy pathology. Arrows indicate lymph node enlargement, lymphadenopathy of sarcoidosis patient. Mass pathology. A mass is any circumscribed lesion bigger than 30 mm in diameter. The term usually refers to a predominantly solid soft tissue structure, but cavitary, cystic, or calcified components may be present to various degrees. Shape and margin descriptors are similar to those used for pulmonary nodules. In addition, distortion or invasion of adjacent structures may be present. The adjectival term mass-like, for example, used in mass-like consolidation, may be used to describe appearance of a given lesion without implying a neoplastic etiology. Mass pathology. We see two masses in right upper lobe and left lower lobe, more than 3 cm, actually 8 or 9 cm in length of lung cancers. Mediastinum anatomy. Mediastinum is an anatomic space located between lungs and extending from thoracic inlet to diaphragm. The current definition of mediastinal compartments is based on CT criteria and includes prevascular anterior, visceral middle, and paravertebral posterior compartments. Mediastinum prevascular compartment anatomy. Boundaries of prevascular compartments are superiorly thoracic inlet, inferiorly diaphragm, anteriorly sternum, laterally parietal mediastinal pleura, and posteriorly anterior aspect of pericardium as it wraps around in a curvilinear fashion. Thus, any vessels contained within pericardium are located in visceral mediastinum. The major contents of prevascular compartment are thymus, fat, lymph nodes, and left brachiocephalic vein. Mediastinum visceral compartment anatomy. Boundaries of the visceral mediastinum are superiorly thoracic inlet, inferiorly diaphragm, anteriorly anterior aspect of pericardium, which envelopes distal aspect of superior vena cava, proximal aspect of ascending aorta, and lateral rim of aortic arch and intrapericardial pulmonary artery. Posteriorly, a vertical line connecting a point on thoracic vertebral bodies 1 cm posterior to anterior margin of spine. The major contents of this compartment fall into two main categories. First, a vascular category, in other words, heart, superior vena cava, ascending thoracic aorta, aortic arch, descending thoracic aorta, intrapericardial pulmonary arteries, thoracic duct, and second, trachea, carina, and esophagus, which share an embryological origin, endodome, as well as lymph nodes. Mediastinum, paravertebral compartment anatomy. Boundaries of the paravertebral posterior compartment are superiorly the thoracic inlet, inferiorly the diaphragm, anteriorly the visceral compartment, and posterolaterally a vertical line along the posterior margin of the chest wall at the lateral aspect of the transverse processes. The major contents of this compartment are the thoracic spine and paravertebral soft tissues. Micronodule pathology. Micronodule is circumscribed and typically round opacity, previously defined as less than 3 mm, but currently defined as less than 6 mm in average diameter. This size threshold serves to distinguish micronodules, if found incidentally, from larger potentially actionable nodules, compatible with current management guidelines. In patients with a high risk for cancer or with an underlying history of cancer, micronodules can become actionable, notably if newly appeared. Micronodules can show same shape and margin, as well as structure and location characteristics as nodules. However, in case of micronodules, these characteristics can be difficult or impossible to assess accurately because of their small size. Of note, concept of individual micronodules is different from concept of micronodular pattern. Micronodule pathology, miliary and random. Arrows indicate micronodules from miliary tuberculosis. Micronodules pathology. We see many micronodules of miliary tuberculosis. Micronodule pathology, miliary metastasis. And these micronodules are miliary in pattern of lung metastasis. You subscribed and liked. Thank you very much. Be healthy, wealthy, and happy. Mosaic attenuation pathology. For description, see pattern mosaic. The mosaic attenuation CT pattern can be caused by obliterative small airway disease, occlusive vascular disease, multifocal interstitial lung disease, or by a combination of the above. In obliterative small airway disease and in occlusive vascular disease, the lower attenuation areas are abnormally hypodense and the higher attenuation abnormally hyperdense, reflecting differences in vascular perfusion, whereas in multifocal interstitial lung disease, the lower attenuation areas are normal and the higher attenuation areas are abnormal. Mosaic attenuation should only be described on CT exam performed in full inspiration. Mosaic perfusion refers to mosaic pattern caused by local variations in lung perfusion. Mosaic attenuation pathology. Arrows indicate the mosaic attenuation of lower density. Mosaic attenuation pathology. Arrows indicate the mosaic attenuation in another patient. Arrows indicate mosaic attenuation in a different patient. Mucoid impaction pathology, also referred to as mucus plugging. Mucoid impaction represents airway filling by mucoid secretions and can be obstructive or non-obstructive. It is often combined with signs of chronic airway disease. Mucoid impaction. Arrows indicate mucoid impaction of Y-shaped in CAT scan and chest X-ray. Mycetoma, fungus borer, pathology. Mycetoma is a mass of intertwined hyphae, usually of an Aspergillus species, matted together by mucus, fibrin, and cellular debris, colonizing a pre-existing cavity. At imaging, mycetoma appears as a rounded structure within the cavity, often showing an air crescent between mass and inner wall of the cavity. On CT exam, mycetoma can have a sponge-like structure and calcifications may be present. Mycetomas are often mobile and changes in position within the cavity can be confirmed by imaging the patient in a different body position, for example, supine and prone. Mycetoma pathology. Arrows indicate air crescent sign of mycetoma. Nodule pathology. A nodule is a circumscribed, typically round opacity, less than 30 mm in average diameter. A rounded lesion more than 30 mm is referred to as a mass. A rounded lesion less than 6 mm in diameter should be called micronodule, a term which serves to distinguish it from larger, potentially actionable nodules compatible with current management guidelines. The terminology described below is intended to standardize the description and reporting of nodules, while acknowledging that nodules represent a morphologic spectrum encompassing both benign and malignant features. Nodule pathology. Arrow indicates a nodule in right lung. Nodule pathology, shape and margin. Nodules can be described as round, ovoid, or polygonal in shape, and as spherical, flat, or elongated in configuration based on their appearance in various imaging planes. Margin of a nodule can be well-defined, ill-defined, depending on appearance of interface with the surrounding lung. A smooth nodule border is even and free of substantial protrusions or indentations, as opposed to an irregular nodule border. Irregular borders can be lobulated with lobule-like protrusions, lobulation, and/or spiculated with multiple radiating small sharp projections, spiculation. Linear components extending from nodule to pleural surface are called pleural tags. Combinations of above shapes and margins may occur. Nodule pathology. Arrow indicates solid nodule, well-defined nodule, round nodule in left lower lobe. Nodule pathology. Arrow indicates nodule, solid nodule, round nodule, spiculated nodule in right middle lobe. Nodule pathology, calcified. Arrow indicates a nodule, calcified nodule in right upper lobe. Nodule pathology. Arrow indicates a nodule, solid nodule, irregular margined nodule in right lower lobe on coronal CT. Nodule pathology. Arrow indicates a nodule, ill-defined nodule, peripheral nodule. Nodule pathology. Arrows indicate ill-defined margined nodule in left lung. Nodule pathology, lobulated. Arrows indicate a nodule with lobulated margin, lobulation. Nodule pathology, lobulated. Arrows indicate nodule with lobulation, lobulated nodule in left upper lobe. Nodule pathology, elongated, calcified. Arrows indicate calcified and elongated nodules of 2 patients. Nodule pathology, fat calcification. Arrow indicates a nodule with fat and calcification, suggesting hematoma. Nodule pathology, attenuation and structure. Based on attenuation, nodules with pure ground glass attenuation are referred to as ground glass nodules. Nodules with pure soft tissue attenuation are referred to as solid nodules. Nodules with both ground glass and soft tissue attenuation components are referred to as part solid. In the context of the lung adenocarcinoma, the ground glass components generally correspond to a lipidic growth pattern, and solid components generally correspond to invasive growth patterns. The term ground glass, solid, and part solid nodule do not necessarily encompass the entire complex morphology of pulmonary nodules and are also limited by low inter- and intra-observer reproducibility among the radiologists. Nodule pathology, ground glass nodule, pure and part solid ground glass nodule. On your left side, pure ground glass nodule in right lower lobe. On your right side, part solid ground glass nodule in right upper lobe. Nodule pathology, attenuation and structure. Nonetheless, these terms are established in literature, and it is likely that they will continue to be used despite their limitations, notably for purposes of management and big data categorization. Note that thin section CT is essential for accurate characterization of small nodules. Based on structure, nodules are either simple or complex. Simple nodules show a single structural component, soft tissue, ground glass, calcium, fat. Complex nodules have 2 or more structural components, soft tissue, ground glass, calcium, fat, air. Of note, simple nodules can develop into complex nodules and vice versa. Nodules pathology, location. Nodules can be described as peribronchovascular or centrilobular depending on their location in relation to other structures. See anatomical distribution. Nodules rising from a fissure should be called fissural. Nodules with direct contact to a fissure but not arising from it should be called perifissural. Nodules arising from pleura should be called pleural. Nodules with direct contact to pleura but not arising from it should be called pleura-based. The term subpleural should only be used for nodules in proximity to pleura but without direct contact to it. Because this term has been attributed variable meanings in literature, the term peripheral is preferred to describe such nodules. Nodule pathology, perifissural. Arrow indicates perifissural nodule of the right minor fissure. Nodule pathology, perifissural. Arrow indicates a nodule of a perifissural location of a major fissure. It is from sclerosing pneumocytoma. Nodule pathology, location. Peripheral is preferred than subpleural. Arrow indicates a nodule of peripheral location. Nodule pathology, location, pleural-based and peripheral located. Black arrow indicates a pleural-based nodule, and white arrows indicate peripheral nodules. Quit smoking, your great job of the year. Congratulations! This is the final slide. You worked hard, very hard today. Congratulations. See you soon on part 4. You have a nice day.